First of all, I want to thank Dr. Pine for coming and visiting us. I want to thank you all for coming to our June Distinguished Visiting Lecture Grand Rounds. It's our last for this academic year, and we are ending it with a bang. As you know, I often like to give you a little bit of sort of the official kind of titles and accomplishments of our speakers, but when I can, I like to say something more personal. So let's start with the official biography. Dr. Daniel Pine is chief of the section on development and affective neuroscience at the NIMH Intramural Research Program. He graduated from medical school at the University of Chicago and then spent 10 years in training and research at the Department of Psychiatry at Columbia. And since medical school, he's been engaged continuously in research focused on pediatric mental illnesses, and can really be considered as one of the really sort of premier scholars who began to thoughtfully inject neuroscience into our understanding and conceptualization of psychopathology earlier in development. And this kind of work and expertise is reflected in over 300 peer-reviewed papers. Dr. Pine's research has focused on has had a strong focus on mood and anxiety disorders in children and adolescents, but particularly, as I said, has brought together the emerging understanding of systems neuroscience and integrative neuroscience to ground what we observe in terms of psychopathology in the clinic in an understanding of how the brain is functioning or malfunctioning. As I said in my email to those I sent to you this morning, it's this very exciting marriage between systems neuroscience and real-world, clinically important observations of psychopathology, which we all need to do when we're working with children and adolescents, and which should be informing our treatment development. So now on a more personal note, I had known of Dr. Pine's work for many years, but I had the good fortune of sitting on the same side of the room as him during a really interesting workshop that NIMH held several years ago now on thinking about cognitive training for psychiatric illnesses and the ways that well-designed cognitive training could harness plasticity and brain mechanisms for a number of different kinds of psychiatric illnesses and perhaps offer an additional kind of treatment modality. And what I was most impressed by and I'll call him Danny now, we've sort of since become friends, was how he participated in this workshop both with enthusiasm and really being open to sort of ideas around plasticity and kind of distributed neural systems and how can we sort of harness plasticity to change how those systems are functioning in psychopathology. But how at the same time he showed a very clear-eyed scientific acumen, being willing to sort of thoughtfully weigh evidence around studies, around approaches, and really, in a sense, not being afraid to challenge some of the status quo that was being brought up in the room, but doing it with sort of a sense of humor and a sense of enthusiasm. And I would say in my interactions with you since that time, that really is kind of who you are, and it's a really a delightful addition to the field. He was the other thing you get to thank Dr. Pine for is when I was considering this position, I'd been recruited and was sort of starting to seriously consider it. We had a phone conversation about something else, probably some cognitive training studies, and I was telling you about it, and you said, oh, you should go there. You'll like it. You'll enjoy it. And he had this very sort of, again, kind of pragmatic but enthusiastic set of reasons for why I should consider making this leap. So I want to thank you for that as well. So welcome.
Thank you. Thank you. Thank you, Sophia, for that really wonderful introduction. And I want to say just a couple of words of thanks really to everybody for the welcome that I've gotten here. So I'm actually a Midwesterner by roots. I think just this year I passed more time lived in the East than the Midwest. So I have about half of each Midwest and the East. And I have to say, I miss it terribly. And I always love coming back for all the great things about the Midwest. The other thing that I wanted to say is I cannot tell you how impressed I have been spending the last 2 days kind of seeing what is going on in terms of all the activities in the university and really bringing together the many different threads related to medical issues, psychological issues, neuroscience-oriented issues, and clinical issues. And that's really going to be the spirit of my talk. I am committed to stopping at 12 sharp. As you'll see, I'm going to be fairly structured in the things that I'm going to say. But there's going to be really only 3 bottom lines that I'll tell you about in a second that are again, going to try to meld both a relatively broad perspective on things, but also to try to give you a couple of bottom lines. I'll say right out from the beginning, I have relatively few conflicts. My main position is with the National Institute of Health, although I will not be speaking as a representative of the United States government right now. I'm going to be giving you my own take on things, and I'm going to try to thread the needle between 2 stances. On the one hand, I am going to try to give you bottom lines, really, that are very dispassionately based on data on the one hand. On the other hand, as you'll see, that particularly for new areas or for areas where maybe we don't have as much data as we would like, I'm going to give you my opinion on things and in terms of where we're going and how to read kind of holes in the literature. I am going to be talking towards the last 15 minutes or so about new neuroscience-based treatments, and it's important to know that nothing that I'm going to say in that final half really has any indication, despite the fact that you will hear people talking about it as if some of the treatments I will describe are clinically useful. That's not the case. And I'm also going to talk a bit about medication. Everything that I'm going to say is going to be off-label use, with a couple of exceptions that I'll point out when we get to them. So these are the 3 bottom lines that I'm going to try to give you. I'm going to start off for maybe 10 minutes, give you a broad way to think about mental health problems developmentally, and then I'm going to narrow down to talking about what we think of as emotional disorders relatively broadly, but in particular, a family of anxiety disorders. And I'm going to try to place those in a broader framework. And then the second thing that I'm going to do is I'm going to try to really review for you the world's literature from randomized controlled trials and give you the bottom lines in terms of what we know about treatment, primarily for anxiety disorders in children. But I'm also going to contrast the data that we have for anxiety disorders with the data that we have for major depressive disorder, because one of the concerning things that you realize when you look at those data is that we do substantially better in terms of treating anxiety disorders than we do for depression, and that has pretty significant implications. And then the last thing that I'm going to do, you'll see that while the data are quite good for the anxiety disorders, there are some serious holes in them. And I'm going to talk about what we can learn from neuroscience in terms of coming up with better treatments. So as I mentioned, I'm going to give you a relatively broad perspective to think about mental health problems. And the overwhelming majority of mental health problems that we see among adults, we can think of those as developmental conditions. That means they're problems that have their roots in childhood. And one of the exciting things about my career is that as time has passed, I can see that this is an idea that developmentalists and child psychiatrists have had for many years, but more and more, really anybody who studies mental health recognizes that the mental health problems that plague society at all ages are largely developmental conditions. Now, when we think about these conditions, we can parse them into largely 3 groups using a set of parameters that I'm going to walk you through on this slide, and you can see roughly 3 groups of conditions. So one thing that we can do to parse these conditions is we can break them down into whether or not they're predominantly genetic or predominantly environmental. So you see in red, there are 2 groups of conditions here that are predominantly genetic, this group and this group right here. And this group of conditions right here is what's called the neurodevelopmental disorders. And the classic neurodevelopmental disorder is autism or autism spectrum disorders. Those are predominantly genetic, and they share that with the psychotic disorders. There are really 2 things that separate the other features developmentally of the neurodevelopmental disorders and the psychotic disorders. One of them is the general level of severity. So on average, the neurodevelopmental disorders have a clearly changing, but in terms of the overall severity, if anything, they tend to be more severe on average early in life than they do later. And then number 2, there are clearly changes in the phenotype. So if you look at the thickness of this line, you can see that it thins as you go with time, but the amount of thinning is also less than in this line for the psychotic disorders. So you can see that these are thicker in terms of the amount of space in this red line and this red line, but you also see in this nonlinear curve the magnitude of worsening is far greater in the psychotic disorders with time than it is with the neurodevelopmental disorders. So the conditions that I'm going to be talking about are really in gray here, and they differ from the psychotic disorders and the neurodevelopmental disorders in that more than half of their variance is due to non-genetic factors. And then you can see, like the psychotic disorders, there's tremendous amounts of phenotypic heterogeneity clinically in these disorders. And unlike the psychotic disorders, where this heterogeneity tends to narrow with time, these remain very broadly manifesting disorders with time. And this is primarily the mood and anxiety disorders, and that's really what I'm going to be talking about for the remainder of the talk. We can break these into largely 3 or 3.5 groups. One category, obsessive compulsive disorder, which differs from the other 2 categories based on a range of features, and I'm not really going to be talking about that at all for the rest of the talk. A second are trauma-related disorders, and I'm not going to be talking about that. The main category I'm going to be talking about are the anxiety disorders, and that includes social anxiety disorder, generalized anxiety disorder, and separation anxiety disorder. I'm going to be discussing these disorders as a group because really that's how we think about them therapeutically, and these disorders have a particularly strong relationship with major depressive disorder, and the transition from anxiety to depression, that's one of these examples of phenotypic heterogeneity. And we also group major depressive disorder in this last group because it is virtually always the case in adolescents with major depressive disorder that they will have virtually always had one of these anxiety disorders. So there's been a range of longitudinal studies that bring home these points. I'm going to show you a data set that I spent about 20 years working with that illustrates with data kind of the bottom line of some of these developmental points for the mood and anxiety disorders that I've been trying to make here. And these are prospective data that followed a group of kids in 2 semi-rural upstate counties in New York. And these were randomly selected children in the community who then received serial psychiatric assessments with standardized structured interviews throughout their teenage years into their 20s, and there were about 700 of these kids, and this illustrates the association between having an anxiety disorder, so this is a clinically significant anxiety disorder, at any time in adolescence, and having any of these mood or anxiety disorders in adulthood. And there are really three take-home points from this slide. Point number one is that anxiety disorders are incredibly common. So about a third of these kids at some point in their development had a clinically significant anxiety disorder. Point number two, they are usually transient. Only 62 of these 253 kids who had anxiety disorders, when they were seen as adults, only 62 of them had a problem. And at the end of the talk, we're going to talk about something called extinction. So extinction is the process where an organism learns to overcome a fear that they might have. When you think about anxiety disorders, you can think about them not so much as disorders in the acquisition of having excessive fear, but in a failure to overcome this fear that the child has acquired. Now, many people think about anxiety disorders as relatively trivial conditions because of these data on their long-term course. But the reason that would be wrong, the reason it would be wrong to think about them that way, is if you look at this last piece of information, and this shows you among the 98 adults who were affected with either a mood or anxiety disorder, this shows you the number of them who had met clinical criteria for an anxiety disorder at one of these waves, and you can see that the overwhelming majority of them had a clinically significant anxiety disorder. So the last thing to say about this is that here I'm really just talking about one small piece of psychopathology. The importance of the developmental perspective is if we were going to look at any chronic mental health problem that afflicts society, eating disorders, substance use disorders, behavior problems, personality disorders, we would see the exact same thing, that the seeds of these problems are exceedingly common during childhood. Most children will do well. They will overcome their initial symptoms, but from the minority of children who have persistent problems, we will see the majority of adults who are afflicted. And Temi Moffitt, in last month's JAMA Psychiatry, talked about data from her study that illustrates over time the incidence of disorders, and you can see that these first high bars here show you how the incidence goes down as you age, and this shows you the cumulative burden from mental health problems throughout life and compares them with non-infectious diseases and dementia. And Temi makes the point about the importance of developmental perspectives when we think about health-related problems in general. All right, so that's point number one. Point number two, I'm going to kind of fairly quickly run through what we know from randomized controlled trials in the treatment of mood and anxiety disorders. I'm going to start by giving you the bottom line, and then I'll give you some more details about the data. The bottom line is we have two good treatments, and again, I'm going to talk about it in a minute, and this is particularly for the anxiety disorders. I'm going to contrast the data in anxiety disorders with major depression, but as you'll see at the end of this section of the talk, we're badly in need of better ones. So the treatments that I'm going to talk about are the selective serotonin reuptake inhibitors in general, although I'll also talk about the serotonin norepinephrine reuptake inhibitors, cognitive behavioral therapy, and the data on efficacy. The data are fairly clear, and I'll put numbers on this and data in a second, that the SSRIs are efficacious for these anxiety disorders that I'm talking about. There's strong evidence for fluvoxamine, which is Luvox, fluoxetine, which is Prozac, paroxetine, which is Paxil, sertraline, which is Zoloft, and ironically, duloxetine is the only agent that has FDA approval for these anxiety disorders. But as I'll show you in a minute, the data for the serotonin, norepinephrine, reuptake inhibitors is actually weaker than it is for the SSRIs, and that's an interesting statement about economics and politics of medication approval. But the bottom line is that they're all efficacious. There's also good evidence for cognitive behavioral therapy, and I'll talk about what I mean by cognitive behavioral therapy in a minute, and then I will also talk about comparative efficacy both in the anxiety disorders for CBT and medications, but then also in particular the comparative efficacy data for the anxiety disorders versus depression. So this is a meta-analysis that my colleagues and I, Joe Kosowski was really the energy behind this, and this puts some numbers on the conclusions that I just gave you. And I'll warn you, there's going to be a lot of details here. I'm going to blow them up so you'll see the bottom line in a minute. This shows you all the randomized controlled trials in pediatric anxiety disorders that were published or not published through 2016. And this is a forest plot that you can see illustrated here for this meta-analysis. These are the SSRIs and these are the SNRIs. So the bottom line, there we go. The bottom line for the SSRIs is that the effect size in these randomized controlled trials generates a Hedges G of 0.71. That's pretty much about as well as we do in any treatment for any mental disorders. So that's approximately the magnitude of the effect of stimulants for ADHD. When you compare this with the magnitude of the effect, for the SNRIs that you can't quite see down here, it's 0.41. So the magnitude of the effect for SSRIs for anxiety is higher than SNRIs, but more importantly, when you compare the magnitude of the effect of the SSRIs for pediatric anxiety disorders with pediatric major depression, you can see that the magnitude of the effect is more than 3 times greater for the anxiety disorders than it is for major depressive disorder. So one point that this drives home is that since we do much better in treating the anxiety disorders than we do in major depression, and since pediatric anxiety disorders are the best predictors of risk for major depressive disorder, it really emphasizes the importance of doing a good job in treating the pediatric anxiety disorders, because not only does that reduce suffering in the child, but it might confer some advantage when trying to prevent depression. So that's one point about comparative efficacy. The second point about comparative efficacy that I'm going to make is about the comparative efficacy of cognitive behavioral therapy versus selective serotonin reuptake inhibitor medications. So there's also strong evidence for efficacy of cognitive behavioral therapy in the pediatric anxiety disorders. I think there are some questions about exactly how strong these data are, and at this point, this is where I'm going beyond the data a little bit to give my opinions, but I'll point out some of the holes in the data for cognitive behavioral therapy. I will tell you, I'm a child psychiatrist, and I see many, many children with pediatric anxiety disorders. And in my hands, when I see a child with an anxiety disorder, I consider cognitive behavioral therapy to be the first-line treatment. And in a minute, I'll say a little bit more about why that is. It has to do with roughly equivalent efficacy data, and again, I'll show you the efficacy data in a minute, and some unease that I have about the potential long-term effects of SSRIs. Again, I'll talk about that in a minute. But when I think about cognitive behavioral therapy, I think about it from a fairly specific point where the therapist has a lot of experience administering manualized cognitive behavioral therapy that follows the procedures that you see outlined here. So this is the best data we have on comparative efficacy. This is the CAM study. It's about 450 children that were randomly assigned to one of 4 treatments that you can see illustrated here: placebo, cognitive behavioral therapy alone, sertraline alone, or combination alone. And there's basically 3 points to take away from this study. Point number 1, if you look at the 2 monotherapies, so this is CBT alone right here, this is sertraline alone right there, both monotherapies beat placebo. All right? So one of the problems in the literature on psychotherapies in general is that most studies have relatively problematic control conditions. One of the really nice features of the CAMS study is that we could compare cognitive behavioral therapy with pill placebo. And this is one of the few instances in child and adolescent psychiatry where a psychotherapy has been shown to beat pill placebo. This is very different from what we see in major depressive disorder. So the comparable study in major depressive disorder, if we were to look at these same 4 cells, the CBT condition would be lying right on top of the placebo condition. So that's point number 1. Both monotherapies were equally effective. Point number 2, when you look at the combination treatment, it was better than both monotherapies. And, you know, the kind of New York Times front story about this, much as it was for the comparable study on depression, was combination treatment is the best. All right? I disagree with that statement. I do not think that this study shows that combination treatment was the best. And to understand why that was the case, you have to kind of think fairly carefully about what the design was here. So the design was, we flipped a coin, all right, and individuals were then told one of 4 treatments that they would get. If it was a 4-sided coin, if it came up 1, they were told you might get placebo or you might get sertraline, all right? If it came up 2, they were told the exact same thing. You might get placebo or you might get sertraline. If it came up 3, all right, they were told they're not getting medicine and they're getting CBT. If it came up 4, they were told that they're getting fluoxetine. They were not told that they might get placebo or they might get fluoxetine. They knew they were getting active medication and they were getting CBT, which the subjects understood to be the Cadillac treatment. So we know from a lot of work that myself and others have done that in general, in the context of a treatment study, but particularly in the context of a treatment study among children, there are very powerful effects of expectancy. So my view of this combination, this difference between this combination treatment here and these 2 monotherapies there, is that I would attribute that difference to this effect of expectancy. So that's why I come away thinking that cognitive behavioral therapy is the first-line treatment, in addition to the safety issues that I'm going to talk about in a second. Now, I'm not going to talk about the major depressive data any further here, but when the similar study was done on major depressive disorder and the data came out very much like this, if you were to look at the combination cell, you would see it was basically very slightly better than the medication therapy alone cell. And that really underlies these concerns about the weaker effects in depression. Yeah. Yeah, the question was the size. That's a very good question. Were the size of the placebo effects comparable in depression and anxiety? And one of the really interesting things throughout the literature, you would think, because anxiety, and I told you about spontaneous remission, you would think that there would be a greater placebo effect in the anxiety disorders. The placebo effect in major depression is consistently larger than it is in the anxiety disorders. And my view on that, again, knowing some of the details of these studies, is it has less to do with expectancy and it has more to do with unreliability and problems in the outcome measures. It's relatively easy to rate anxiety in kids reliably, and it's that factor more than the characteristics of the condition that I think accounts for the lower placebo response rate in the anxiety disorders. All right, so that was all the good news. Here's bad news number one, all right? So the criterion to get into this study in terms of severity is that the children had to have a PAR score of 10, all right? So as you can see, I was just talking about these monotherapies as the first-line treatments that I would offer, and particularly CBT. When you look at the CBT cell here, this is the score at the end of the study. All right. So sure, it was cut in half, and that's a big effect size from a quantitative standpoint. But when you look at the mean in the post-treatment cell, more than half of the kids after the study would have still met criteria to be randomized. So that's not good. It tells us that we got to do a lot better. Even more concerning, when one looks at the follow-up data, these are the follow-up data that were published a couple of months ago, and this shows you the data on how many children functioned well. And the main thing to look at are just the blue bars here. So this shows you the number of kids from these 450 odd kids who were consistently well while receiving all the treatment that they needed. So you can see only 20% of these kids were considered well, despite getting the best treatment that any of us could survive. So, again, the bottom line here is that we do have two good treatments, but we've got a lot further to go before, we can feel really confident about it. All right, so now I'm going to talk a little bit. I'm going to shift from talking about what we know based on data to moving into neuroscience. And I'm going to start off by talking about my concerns about potential adverse effects. And this always makes everybody in the audience a little nervous, including me. So again, I'm going to try to thread a needle here, and I'm sure a lot of questions are going to come up about this. I think cognitive behavioral therapy is the first-line treatment. I think it is perfectly reasonable to use an SSRI in a child with anxiety disorders who has failed cognitive behavioral therapy, and I use selective serotonin reuptake inhibitors as the first-line treatment for major depressive disorder. All right, so I'm totally comfortable using medications. However, I think we don't know nearly enough about how these medications work and what their effect is on brain development. And so now I'm going to describe a study for you that was published about a year ago. So most people know that most of the serotonergic neurons have their cell bodies in the brainstem, and they ascend very broadly throughout the brain. And here you can see two proteins that are particularly important. I'm going to be talking about one in particular, the 5-HTT. You can see it illustrated here. That's the serotonin reuptake inhibitor. Now, what people may or may not know is beyond their role in regulating homeostasis in the mature mammal, they are vitally important as sculptors of brain development. So, as I was doing a lot of my work on selective serotonin reuptake inhibitors, and I became aware of a lot of literature in rodents that suggested that there was a window in which SSRIs could exert particularly profound effects on brain development. We launched a study in non-human primates, and I'm going to talk about the results from that study. So this is the published paper, and the paper took 32 non-human primates, these are rhesus macaques, and it randomized them at age 2 to age 3. So for a macaque, it's about a 4-to-1 ratio in terms of the lifespan as we compare them to humans. So a 2-year-old rhesus is approximately an 8-year-old human, all right? So we randomized them to either fluoxetine or placebo from 2 to 3. So you can think of that as treating a child from age 8 to age 12, all right? Everybody was blind. Half the monkeys got placebo. Half the monkeys got fluoxetine. We monitored their blood levels. So their blood levels were comparable to and their CSF levels. They were comparable to what a child would receive. We took them off the medication at age 3, and we let them grow for 2 more years. So you can think of that as roughly 8 years in the human. All right? And then what we did is we measured the density of their serotonin reuptake inhibitor transporter. Serotonin reuptake transporter. We measured the density using PET in these now adult monkeys who had or had not been treated. And there are 2 main things to take away from this. The first is this shows you the average level of binding everywhere throughout the cortex. So I can tell you this is an extremely large effect, all right? As large as we really see in biological studies of these kinds of parameters, number one. Number two, if you look here, you can see that there was the expected regional distribution of this transporter binding. There were regions, and this is kind of in the region of the anterior temporal lobe and the insula. There were regions where there was no overlap in terms of the density of the transporters in the treated and not treated monkeys. Now, 2 other things to say about this. One is that there were other features of the design. We measured a bunch of different behaviors in these monkeys, and the monkeys also were stratified into anxious and non-anxious monkeys, and there were no findings in terms of did the medicine have long-term effects on behavior? It did not. Or did it interact with the baseline level of anxiety in the monkeys? Again, it did not. You know, once you start looking at those factors, you're talking about 8 monkeys to a cell. So I would take that with a bit of a grain of salt. So that's number one. Number two, we really don't know if this is bad or good. So that's why I made the point about I still feel comfortable prescribing medications when they're indicated. And there's as much evidence to say that this might be beneficial as there is to say it's harmful. However, it reemphasizes to me how little we know about what we're actually doing when we treat a child with the selective serotonin reuptake inhibitor. And the way that I think about it is from animal studies, including studies in non-human primates, there's every bit as much evidence that stress that goes unaddressed is harmful for the development of a mammal as there is that SSRIs are harmful. So I feel, again, completely comfortable using SSRIs in that context. On the other hand, particularly for a child with anxiety disorders who has remitted from their SSRI, based on data like this, I like to take children off their SSRIs once they've had a stable period and they're in a low stress period after a year of being treated. All right, so I'm sure hopefully I've given this talk a fair amount of times, and hopefully I addressed all the questions that came up, but we'll have plenty of time to, talk about that. All right, so now I'm going to kind of shift in the last 15 minutes that I have and talk about future treatments, and I'm going to really give you one example where I'm going to talk in a lot of detail, and then I'll give you another example in less detail. And both sets of examples relate to how we can use neuroscience to start thinking about coming up with better treatments. And there's a couple of global things that I would say about that. The first is that we need to start thinking about the problems that we see in our patients quite differently. We need to identify characteristics, behaviors, phenotypes where they emerge out of neuroscience so that when we start manipulating them, we have a better idea of how any clinical effect we might have relates to what's going on in the brain, number one. And then number two, this requires a very deep partnership with neuroscience-oriented clinicians and neuroscientists. And again, this was one of the really exciting things about being here. Minnesota is really emerging at a place where this kind of work is being done. All right, so I already said this. This is implicit with what I was just saying, and there are really three ways that I think about neuroscience, and I'm going to talk about all three of them. One is that it really helps me to talk with patients, and I'll give you an example of that. Second is it generates new ideas about new treatments, and I'm going to give you a specific idea about that. And then it also helps us tailor treatments to individual patients. So as I mentioned, the really important thing that initiates this work is selecting a phenotype. And the kinds of phenotypes that we work with are much more narrow than what you might be used to thinking about clinically. So this is really the phenotype that you can see depicted right here. So this shows you mature mammal here, right here, this guy, and he's engaged in a neutral motor task. He's walking through the woods, all right? And the phenotype that we're interested in is the capacity for this stimulus right here, this threat, to interrupt this neutral motor task. Now, this looks like a relatively simple behavior, but it's actually quite complex. And two aspects of the behavior that are particularly important to us, you can see that there's a motor component. So he's taking the stick and he's going to avoid the snake with the stick. And there's also an eye movement-based component that he is monitoring the threat. And in the kinds of behaviors that we monitor in our patients, we see the exact same type of phenotype, and it makes it quite difficult to talk about vigilance versus avoidance, because here in this phenotype, in the same instance, you see a sign of avoidance at the same time that you see a sign of vigilance. Now, we've begun to map the neural circuitry of these underlying behaviors, and I'm not going to go over the circuitry that's depicted here, but the important point to take away from this is that imaging studies and lesion studies in non-human primates have taught us that there are multiple components to this phenotype. You can think about it much like the reflex you have when you pull your hand off a stove. All right, so aspects of this response right here are automatically deployed. We are not aware of them, and again, I'm going to give you an example of that in a minute. And other aspects of them are like when you realize after you pulled your hand off the stove, oh, gee, that stove is hot. All right, so you can think about this phenotype in the same way. Now, this is the task that we have used most frequently. I will tell you it's a task we're moving away from for reasons that I could tell you about if you want to hear about them. But I spent about 20 years working with this task. It begins with a warning cue, and then the subject's task is to do something with this arrow. They might have to make an eye movement towards that arrow. They might have to indicate the color of the arrow. They might have to indicate the direction that the arrow points. And you can think of that like this walking through the woods. It's analogous to the guy walking through the woods. And the thing that's analogous to the snake is that between this warning cue and this neutral motor task, we present stimuli that look like this. So there is an angry component to the stimulus right here and a neutral component to the stimulus right there. And based on the way in which these stimuli affect performance on this neutral motor task, we can say something about the effect on attention. So for example, if the individual's attention was captured by this stimulus, we might see that their eye movements would have a prolonged fixation on this cue, and they might facilitate performance on that trial. So, as I mentioned, we've had about 10 different brain imaging studies where we've mapped the underlying circuitry associated with performance on this task, and the main findings that we get relate connectivity between the amygdala and ventral parts of the prefrontal cortex across these different kinds of trials. These congruent trials where the angry face and the arrow appear on the same side, these incongruent trials where the angry face appears on one side, the arrow appears on another, and the neutral trials appear on the third. And I'm going to show you data in 105 approximately 13-year-old adolescents, half of whom have an anxiety disorder, half of whom are healthy. And this illustrates the most consistent finding that we get, which is that there are no differences in connectivity to the neutral trials, and there are opposite patterns of connectivity in these congruent and incongruent trials. And this gives you a finding that you can see illustrated here, where the healthy group has a positive value. Remember that, because we're going to show you how this relates to treatment outcome in a minute, and the ill group has a negative going finding. Now, remember what I said about the reflex that you have when you pull your hand off the stove. So maybe part of the reason and part of the problem that we have with cognitive behavioral therapy is that cognitive behavioral therapy all involves what we call declarative learning. So we tell the individual what to do, and maybe if we're trying to alter this reflex, we're not going to be able to change that reflex by telling people what to do. And this relates to the conference that Sophia and I attended. And so the thing that we've been doing for many, many years is we've been using cognitive training techniques to try to alter this reflex. And the main one that we use, the one that I'm going to tell you about now, we expose children to many, many hundreds of trials where a threat stimulus appears up here, and then the cue always appears down there. And what we and others have shown is that with time, kids naturally develop a tendency, if they're exposed to this training, to automatically shift their attention away from threat. All right? And we and others have done many randomized controlled trials where we compare this treatment as a standalone treatment to a treatment where kids are randomly exposed to 50-50, half of the incongruent and half of the congruent trials. And we and others find, I would call a statistically robust, but clinically I would say not that large effect. So enough to make this interesting and worth pursuing on the one hand, but not enough that I would take out and give to to patients yet. There are other reasons I wouldn't give to patients yet that we can talk about in the question and answer period. But the more important thing about this is, from a theoretical perspective, you can start thinking about tailoring different components to patients with different perturbations in their anxiety-related functioning. So the metaphor that I use is hitting a baseball, and that your twins are doing quite well, so this should be something that you should feel good about thinking about right now. But it's also like how you think about learning how to drive a car. So my favorite scientist growing up was a guy named Ted Williams. People probably know that Ted Williams was a great baseball hitter, maybe the greatest baseball hitter ever, but he also knew a lot about science. And the thing that Ted Williams knew is that whenever you have a rapidly deployed motor act, like swinging a baseball bat, there are many components to learning how to master that behavior. And again, you can think about learning how to drive a car. So when you teach kids how to drive a car, before they get in the seat and before they start driving, you teach them the rules of the road. So Ted Williams said the same thing about hitting a baseball, and for Ted Williams, the big thing was knowing the strike zone. So Ted Williams taught all of his hitters what was their favorite pitch. And you can see that this shows you what Ted Williams thought about when he was walking up to the plate. He was looking for these pitches right here because he knew those were the pitches that he handled the best. And for my patients, I think about cognitive behavioral therapy as a little bit like that, or a little bit like learning the rules of the road when you drive. So for example, from an attention standpoint, we teach our patients with social anxiety disorder that when they're giving a speech, if they start getting afraid, they should have their safe person and their dangerous person. So Dave Reddish is my dangerous person. So if I start getting nervous, I'm going to look away from him. And Sophia is my safe person. I'm going to look at her and I'm going to be reassured. All right? That's a little bit like learning the rules of the road. We have to consciously think about that. All right? Once kids learn the rules of the road, though, we don't just put them in the car and let them drive. We force them to practice over and over and over again so they can develop automatically deployed, rapidly elicited behaviors. And Ted Williams said the same thing about hitting a baseball. It wasn't enough to know the strike zone, but you had to practice the same motor act over and over and over again. And that's why when people would see Ted Williams walking down the street, he would always have something in his hand, and he would just be swinging the bat over and over and over again. Well, so maybe this idea of cognitively training some things and talking with patients about other things is a little bit like this. And so in the randomized controlled trial that we reported last year, we took a group of 72 patients with anxiety disorders. They all got cognitive behavioral therapy, and then they were randomized to receive these same two treatments that we talked about, this statistically robust but clinically marginal effect here. We found the same magnitude of effect when you added this on top of cognitive behavioral therapy. All right? So if you remember everything that I said about the effect of medication added to cognitive behavioral therapy, the effect of adding this cognitive training was as large as the effect of adding medication to cognitive behavioral therapy. But here, this effect is comparison of two blinded treatments. So it removes the expectancy effect because kids couldn't tell which treatment they were receiving. The last thing to say about this is that the other thing that we did in this study is that we embedded the clinical trial in an imaging component so we could examine the degree to which imaging data at baseline predicted which treatment the kids would respond to. And you can see that at baseline, if you received that active treatment, it really didn't matter what your baseline brain function was like because you were getting the active treatment that would ameliorate it. So you were going to be okay. If you did not get the active ABMT, however, and remember what I said about low being bad, right? This is that same connectivity between the amygdala and the insula here on the left. You can see that the worse off you are at the beginning, the worse your response to treatment is going to be. Now, I don't give this example because I think this is the kind of thing that we're really ready to do on a large scale, or even if I think it's the kind of thing that we should begin to think about for our patients, but it gives you a path that I think we really need to follow when we develop other treatments like this. Now, the last one I'm going to talk about, one last set of findings, just to give you another flavor, another idea of this kind of treatment. We're much farther behind in this area, and so I'm not going to present any data. I'm really just going to give you this idea, and it gets back to this idea of extinction. Remember when we talked about overcoming your anxiety, I mentioned that there's this process called the extinction of condition or fear. So threat conditioning is the process where organisms learn to be afraid. So you can see here that a neutral stimulus, this sound, is paired with a shock, and the organism is afraid when it hears this neutral stimulus. Extinction is the process where the organism learns to overcome their fear. And so you can see here, we present this stimulus over and over again, and the organism learns not to be afraid. We used to think about extinction as a form of forgetting. We used to think that the rodent forgets that the stimulus is dangerous. Over the last 20 years, we've learned that this isn't the case. It's a form of new learning. And because it's a form of new learning, and again, this comes back to this idea of extinction, and we think that much as the rodent learns to not fear the sound, we think that analogous processes happen when kids learn to overcome their anxiety. So we know a lot about the underlying molecular architecture of this form of new learning in the rodent, and we can use what we know about this underlying molecular architecture to come up with a whole host of new treatments, much like the ABMT, the attention bias modification treatment that I just talked about. But here, instead of targeting this reflex of attention, we're targeting this underlying neural circuitry that we think facilitates extinction. So some of you might have heard of the compound D-cycloserine. So this is an antibiotic that has this off-target effect that it binds to the NMDA receptor. You can see that right here. And much like the finding for ABMT that I talked about in our hands, we see a similar finding when we combine D-cycloserine with cognitive behavioral therapy with the idea that it facilitates extinction. All right, so to come back to where I started, I've really tried to have this talk unfold at two levels. At one level, I've tried to give you broad points about what we know about development in general and the importance of development for all forms of psychopathology, but particularly for the emotional disorders and the anxiety disorders per se. But at a deeper level, I've tried to talk to you about what we know about efficacy of treatments. And I really do think for the field to move forward, what we need to do is we need to ground what we're doing in terms of neuroscience-oriented research, what we already know about effective therapeutics. And most importantly, we need to ground that in terms of testing ideas that emerge from neuroscience to see if we can come up with novel treatments that then we can use to shape the discussions that we're having with patients and eventually tailor these new treatments to individual patients based on assessments of the underlying biology. So with that, I think I'll thank you for most of your attention. I saw about 4 people sleeping, so it's better than I usually do, but I'll open it up for really any questions that anybody has about anything.
I guess if they're sleeping, they're not anxiety provoking.
Not enough. I should have called on people.
So to be clear, with your macaque study, you saw over the 8 years after the SSRIs were stopped.
2 years, but it's 8 years if you think about a human.
Equivalent, sorry. That over that 8 years equivalence, they did not regain the density of serotonin transport receptors in comparison to those that did not receive the SSRIs, but they did not have behavioral or apparent anxiety differences between the two groups.
The short answer is you got it correct. The one caveat I would say to that is we only scanned them once. They only got one PET scan. So we don't know, they could have had a really high level when they were treated and then it came down. And if we had scanned them 3 years later, maybe it would have been normal. Or for all we know, it could have been normal when we treated them and then maybe it increased over time. And we saw no change in behavior. That's correct.
So when you look at the data from the rodent studies, do you see this contrasting to those, though? As I understood it, there could be some long-term anxiety-like behaviors in most studies.
Yeah, I would say 3 or 4 things that are quite different about the rodent studies. The first thing I would say is that the regions where we saw the biggest differences in the non-human primates, like anterior temporal lobe, our association cortex, are regions where rodents don't have much circuitry. So that's number one. Number two, the developmental state of the rodent brain and the studies that target it is radically different than in the non-human primates. So most of the studies in rodents find a particularly large effect in the first week of life in the rodent. And when the rodent studies happen later, equivalent to the age period when our study happens, they do not find the effects that we find. And the thought is that the age at which the largest rodent effect happens in terms of the state of brain development, it's roughly equivalent to in utero. So you might know that there's, I see Jed Ellison, Jed probably knows more about this than me, but there's some concern about exposure in utero to selective serotonin reuptake inhibitors and risk for autism. I think that that's more analogous to what we did in the non-human primates. The third or fourth, I'm losing count, things to say is that most of the rodent studies use genetic manipulations on top of selective serotonin reuptake inhibitors and find that the effect of the medication depends quite profoundly on the genetic background, and those genetic background factors are probably much larger than any of the things that we're seeing. And then last of all, just for ethical reasons in terms of what you can do with non-human primates compared to what you can do in rodents, the magnitude of the threat that the rodents are exposed to is markedly greater than. So I think the only thing that you can say from both sets of studies is that development is particularly important and that we should not be overly reassured by the fact that, there's no smoking gun for SSRIs.
Thank you.
My question is about fear, about facilitating extinction. And so I think one of the reasons CBT doesn't have good durable outcomes is that fear extinction is highly context specific.
Yeah.
So what are your thoughts about augmentation strategies that might facilitate generalization?
Yeah, so I would say 3 or 4 things about it, and you're absolutely right that a lot of people are concerned with the context dependency of extinction and are trying to do a whole bunch of novel things, none of which have worked very well, I will say. It's probably the most exciting one is, and I have to say I'm fairly skeptical of this literature, but it is pretty interesting. There is evidence, mostly from studies in rodents, so there is some evidence from studies in humans, that if you conduct extinction studies in a certain way, that if you re-evoke the fear right before the extinction episode, that you can permanently erase the fear, because there's thought to be this malleable consolidation window where the memory is more labile. And there are a fair number of people, Daniela Schiller is probably the main one, but there are other people, Kint in Europe, who have tried to erase fears by using this technique. So that's one. The second is that there are a lot of people who think that extinction is, and the kind of learning that happens with extinction is a form of reinforcement learning. So people are trying to use procedures from the reinforcement learning literature to maximize the amount of extinction. So for example, surprise is a potent way to increase the magnitude of what's called a prediction error. And there are a lot of people who think that part of the problem with extinction is that we don't surprise our patients enough, right? So that they should show up for their therapy and like gorilla should be, waiting in their office. So that's the second thing. Again, interesting idea. It hasn't really worked that much. The one that I think makes the most sense, but it also hasn't worked, is people are trying to do much more extensive, much more context variable extinction episodes. So conduct extinction in as many different contexts as you can. Again, none of that's really worked so far. But it's all pretty interesting stuff. Was there a specific thing beyond what I said?
I was just curious about your thoughts.
Yeah.
Thanks.
Yeah,
Danny, that was great. Thanks for your presentation.
Thanks.
Question about some of the early data that you showed from the upstate New York. What do we know about the groups of individuals at school age, those who aren't showing symptomatology but show the later expression during adulthood, those who show it early and it's sustained, and those who show it but it's more transient? Do we know anything about differences between those kids at school age?
Yeah, couple things to say about that. The first thing is pretty much all the people who are affected in adults have some anxiety when they're kids. It pretty much never comes out of nowhere. The reason that the rates were fairly low is that the slide that I was showing you was for clinically significant anxiety. If we were to look at things like, typical fears, fear of the dark, for example, or, temperament ratings. Pretty much every person who was affected had some problem. So that's the first thing to say. Second thing to say is one of the really maddening things, and this is one of the reasons I got so interested in neuroscience, one of the really maddening things when you try to look clinically at predicting who does better and who doesn't, there's not a lot. So age doesn't really matter. The precise nature of the anxiety doesn't matter. If anything, the more treatment the kids got, the worse off they were. This is an observational study, so we think that it's what's called confounding by indication, meaning that the kids who were most sick get the most treatment because they're sick, not the other way around. The only thing that really stands out, which, it's not very helpful, is the overall number of problems that an individual had. That was the thing that predicted who did worse. So if you were a kid with anxiety disorder, and you also had cognitive disorder, and you also had ADHD, and you also had substance abuse, and you also had an eating disorder, you were particularly likely to still be affected. That's really the only thing. Yeah. Not very helpful. None of it's very helpful. And I don't put much promise in it, quite honestly. Clinically, I don't think we're going to do much better than we've done. Yeah, Katie.
Back to the macaques.
Yeah.
I'm sorry for not knowing this. Has there been research on macaques starting where they start in adults and then scan them at 2 years
There
later?
has been. They haven't been. They're, number one, the effects are not as robust as they are, and they're not rhesus. They're cynomolgus monkeys. But the other thing is nobody has done the long-term exposures that we've done or taken them off and then imaged them when they're off meds. So we don't know if you did the exact same experiment in an adult rhesus, if you would have the exact same thing. Now, again, remember the study took 7 years. Mm-hmm. So, we didn't do anything else with the monkeys. They were living in really, for a monkey, really nice, quarters. These were not caged housed monkeys. They lived in large pens in social groups. And so that's a really, really expensive study to do.
Based on kind of what we do know, it seems like it's a developmentally specific.
Well, the data are very clear in the rodents that you do not see after maturity. You do not see
changes.
Yeah.
Thanks, Danny, for a great talk. I'm just curious. I wanted to understand for the ABMT study, ABMT plus cognitive plus CBT study. What was the ordering? Did they get CBT first and then ABMT, or were they simultaneous?
Yes, simultaneous.
They're simultaneous. Do you have any thoughts about whether, again, speculating, whether there's an optimal way to order these?
Oh, God. No, I'm not even convinced that, I'm convinced that CBT works. Mm-hmm. I think CBT is the best treatment we have, number one. I'm convinced that it's worth me spending/wasting my time studying ABMT, number two. Number three, I'm convinced that the kind that I've been using is not robust enough. So there are better. All our training now uses eye movements. We don't train motor response anymore, and it uses much more engaging procedures. Until we can demonstrate comparable things with those kinds of manipulations, I wouldn't speculate about timing.
And one thing, either to you or any of the child psychiatrists, this not being my area, I was very curious at the relatively poor response rate to antidepressants in childhood depression, which is not something I had known.
Oh, it's terrible.
What are the thoughts about that?
Well, I would say two things about this. One is it's one of the biggest problems that we have really in all of child psychiatry because it's such a bad problem and we've been spending so much time and energy on it. The second thing is I would come back to the guy who asked the question about the placebo response rate. I think that there are serious problems with the child and adolescent depression phenotype. I don't think we do a very good job in terms of how we assess it. And I think in the bigger industry-sponsored trials, I think we do a particularly bad job. And I think it needs a lot of work. I was talking with Gail Bernstein and I were talking about ecological momentary assessment. We're doing a lot of that with anxiety, and that's another whole interesting story. But I do think particularly in the area of youth depression, I think that would be a really promising avenue. So,
just to follow up on Sophia's first question, I think the best evidence that we have from some of our labs related to some of this cognitive training stuff, and seems to be apparent in your data as well, is that there's clearly some winners and some losers as far as who gets assigned these things.
Excellent. Excellent point.
And there's obviously individual differences in response.
Yes.
Something that we're after, and I'm curious your thoughts as far as how you might stratify at baseline to decide who gets what.
Excellent question. So I will tell you, with all of the best ideas in the cognitive training stuff that I've had are really my colleagues' ideas, Yair Bar-Haim, and his idea, and we do have data to suggest that this is the case. He's an electrophysiologist. So he quantifies the degree of mismatch negativity that somebody has in their first training exposure. Because if you think about the training, that there is a expectancy violation in that first we do a task where the target is 50-50 behind one of the stimuli or not, and then when we start doing training, it always appears usually behind the neutral stimulus. People aren't aware of that. They can't tell you that. But everybody eventually, if you do it enough, everybody develops a mismatch negativity when they start not noticing, when their brain starts detecting that change in contingency. The earlier, better, more quick you are at noticing that, the stronger your benefit that you get from the training. So, it's operating on whatever level mismatched negativity, pre-consciously, unconsciously, and there's some form of learning. I can tell you other things that we've thought of that turn out not to be the case. We've done designs where we tell people the training, so we do all 4 groups. You get active, you're told you get active. You get active, you're told you get placebo. You get placebo, you're told you get placebo. And you get placebo, you're told you get active. It doesn't matter. What you tell people doesn't matter. That was kind of interesting. It doesn't affect their training or the response. And then the other thing we did, which was very interesting, is we trained people and then had them nap. And that, because there's some of these ideas about, consolidating implicit learning with sleep. That didn't make a difference. So the most promising thing was this mismatched negativity. The other thing I will tell you, the training that works much better is that we have people pick their favorite music. And then what we do, and again, this is Yair, all these ideas were Yair. We have people look at an array of faces that has a mixture of negative valence and positive valence faces. And then we monitor their eye tracking, and that in the active treatment, and we ask them to pick their 100 favorite songs. So then we load them up, so they're going to listen to their 100 favorite songs continuously. And then whenever they look at a negative valence face, the song shut off. Yeah, so that works much more robustly in terms of the magnitude of the effect, both on the attention effect, but then also clinically. So and I think it has to do with 2 things. One is the reliability of the biological phenotype. We just get much more stable indices with eye tracking than we do with button press. But then the second is the degree of engagement. Most of the training that we do, it's horribly boring, and the therapist stands over the kid and watches them do the training. And if you don't do that, they don't do it. So.
Well, thank you again for
Absolutely.
You have been disconnected from the meeting.